very much. Okay, it sounds in India it's the end of the day. I think so. I'll speak about neonatal hypoglycemia, and this is when time matters. Of course, hypoglycemia is a common problem. It's a biochemical finding and not a diagnosis by itself. Interpretation of blood glucose in the context of clinical and lab picture is very important. Don't forget to look for the cause, and this is when time matters because we need to save a neonatal and infant brain. Now, looking at the glucose physiology, glucose in the blood passes to the cells to provide energy. In the muscles, it's stored as glycogen to preserve energy for movement, and in the liver, it is stored as glycogen. Maintenance of blood glucose level is very complicated, and the source is mostly from the diet or glycogenolysis during early fasting or gluconeogenesis when there is prolonged starvation more than 18 hours. And then in the blood, it's used either for oxidation or converted to lipids by lipogenesis or stored in the form of glycogen. Regulation of the blood glucose level needs a perfect balance. When the blood glucose rises, insulin takes the upper hand, and this is the only glucose-lowering hormone, as we all know. And this decreases the blood sugar level. When the glucose drops, here comes the role of the counter-regulatory hormones, increasing the blood sugar level, and this returns the blood sugar back to normal. Now, looking at the biochemical changes during fasting, the pancreatic beta cells are very sensitive to changes in the blood glucose. First, insulin secretion is switched off when glucose concentration reaches 4 millimoles per liter, and then glucagon increases and adrenaline, and finally, there's an increase in the serum cortisol and growth hormone. There are some metabolic and endocrine changes that occur at birth in a healthy term newborn, based on adequate glycogen stores, glycogenolysis, gluconeogenesis, and the counter-regulatory response. It's very important to note that a normal infant at term shows immediate postnatal fall in the blood glucose during the first 24 hours from values close to maternal levels to around 45 milligrams per deciliter. And that's why neonatal hypoglycemia is defined when blood glucose level is less than 30 milligrams per deciliters in the first 24 hours or less than 45 milligrams per deciliter thereafter. And after 72 hours of age, all newborns should have a blood sugar of more than 70 milligrams per deciliter. There is a very long list of the causes of neonatal hypoglycemia, either due to poor glucose production like prematurity, SGA, maternal beta blockers, inborn errors, increased demands due to sepsis, hypothermia, hypoxia, hyperinsulinism, a very important cause in infants of diabetic mother, congenital hyperinsulinism or Beckwith-Wiedemann, and finally we have endocrine disorders. Luckily, there are some cases which are transient and resolve within few days to several months, either due to maternal cases or due to perinatal stress etiology. When having a neonate like this with jitterness, irritability, high-pitched cry, hypotonia, lethargy, poor feeding, hypothermia, seizures, tachypnea, apnea, cyanosis, and cardiac arrest. Putting these together, these are non-specific symptoms which could occur in any sick neonate. And that's why measuring blood sugar and electrolytes is very important in any neonate who's not doing well. And let me start by this 2-day-old neonate who was born preterm, SGA, 1.2 kilos, RDS, the mother is not diabetic, the parents are not consanguineous, the baby was asymptomatic, and screening the blood sugar proved to be 42 milligrams per deciliter. It was low. CBC, CRP electrolytes were normal. And how to deal with such a baby when managing asymptomatic hypoglycemia in high-risk neonate? If the random blood sugar is less than 25 milligrams per deciliter, we follow the protocol of symptomatic hypoglycemia. From 25 to 45, try oral feeding and monitor blood sugar every 30 to 60 minutes. Still less than 45 milligrams per deciliter, follow the protocol of symptomatic hypoglycemia, more than 40, monitor the blood sugar every 6 to 8 hours, and stop after 48 hours. So the conclusions from such a case are SGA, maternal toxemia, and birth asphyxia are risk factors for neonatal hypoglycemia that should be screened for. If asymptomatic and blood sugar is less than 25, we follow the protocol of symptomatic hypoglycemia. If asymptomatic and the sugar ranging from 25 to 45, give oral feeding and reassess. Mechanism of hyperinsulinism in SGA babies is not fully understood, and in most of these cases it's transient, and sometimes it can last for a few months where diazoxide could be offered as a therapy. Another different story is this 20-day-old newborn who was born full term, cesarean section, developed neonatal jaundice. The mother is not diabetic. The baby developed recurrent generalized tonic-clonic convulsions, lethargy, poor feeding, micropenis, otherwise genitalia were normal. The baby also had depressed nasal bridge and midfacial hypoplasia, and the father was short, 158 centimeters. All his metabolic profile was normal apart from indirect hyperbilirubinemia and a very low random blood sugar. So the baby has got symptomatic neonatal hypoglycemia, and based off that, IV glucose 10% 2 cc per kg was given, and then glucose infusion at a rate of 6 to 8 milligrams per kg per minute. And then we check the blood sugar after 30 minutes until euglycemic, and then 6 hourly. If the blood sugar rises above 45, stable on IV fluid for 24 hours, we taper the infusion rate by 2 milligrams per kg per minute, and then we stop when the rate is about 4 milligrams per kg per minute. If the blood sugar is less than 45 milligrams per deciliter, repeat the bolus and increase the infusion rate up to 50 milligrams per kg per minute. And if we reach this point, exceeding 15 milligrams per kg per minute, it's very important to look for the cause. So we gave IV glucose and the baby is not responding to usual lines of treatment. The blood sugar is still going down. So the next step here is to withdraw the critical sample in a sample where the blood glucose is less than 40. In the urine, we look for the ketones, organic acids, and reducing substance, and the components of the critical blood sample, the glucose, insulin, C-peptide, growth hormone, cortisol, thyroid functions, beta-hydroxybutyrate, free fatty acids, and ammonia, and putting them together to diagnose and treat according to the cause. So when facing a case of persistent hypoglycemia, and by persistent we mean hypoglycemia not responding to usual lines of treatment for more than a week, it's either non-ketotic or ketotic. For non-ketotic, when measuring free fatty acids, if high, this is a fatty acid oxidation defect. If low, we think of congenital hyperinsulinism. And of course, there are specific criteria for hyperinsulinism that I'm going to focus upon. If ketotic, look for acidosis and hyperammonemia in order to exclude organic acidemias. If not, if there is hepatomegaly, no, endocrine diseases should be excluded, of course, by lab. If there is hepatomegaly, measure lactate and pyruvate, which if high, this points towards gluconeogenetic defects. If normal, we screen reducing substance in urine. Of course, if positive, this is galactosemia and hereditary fructose intolerance. If negative, exclude glycogen storage disease, which of course has got certain features diagnosed by hepatologists. Now, going back to our baby, the baby who presented with neonatal hypoglycemia not responding to usual lines of treatment, as you see in the labs, the glucose was low, and this is a ketotic hypoglycemia. The rest of the profile was fine, apart from a very low growth hormone in the critical sample. Also, the IGF-1 was found to be very low. So here the diagnosis is a straightforward case of congenital growth hormone deficiency. And the clue in this neonate was hypoglycemia and or micropenis. Also, MRI showed antipituitary hypoplasia, as you see here in the yellow arrow. And genetic testing revealed heterozygote mutation leading to splicing out exon 3 of GH1, and this is type 2 idiopathic growth hormone deficiency. And the baby responded very well to growth hormone and is doing fine. And these are the types of growth hormone deficiency. And our case was fitting with type 2, and the response to growth hormone was good. So the conclusions here are, the clue for diagnosing growth hormone deficiency in neonates is micropenis and or hypoglycemia. Congenital growth hormone deficiency is diagnosed by the critical sample and not by growth hormone provocative test. Remember to exclude congenital growth hormone deficiency as a cause of neonatal hypoglycemia. And with congenital growth hormone deficiency, exclude pituitary hormone defect and perform MRI celatosica to exclude anomalies. Another totally different story is this 1-month-old baby who was born full term. He was referred to us as a male with bilateral undescended testes. The parents are first cousins. As you see, genitalia is pigmented. The phallus, 3.5 centimeters. There is a single opening at the phallic tip. Bilateral impalpable gonads. The baby presented shocked, dehydrated, and disturbed level of consciousness. The random blood sugar was very low. The sodium low, potassium high. Of course, this is adrenal insufficiency. And here it was clear that the cortisol was very low, ACTH high, aldosterone low. So this is a case of hypoglycemia due to adrenal insufficiency associated with genital anomaly. And so the next step was to measure 17-hydroxyprogesterone, which was very high, as you see, 44 nanograms per ml, a very high value. And the karyotype was XX, in spite of the fact that the baby was referred as male with bilateral undescended testes. And the rest of the profile was normal. Ultrasound revealed uterus and ovaries. And so the final diagnosis here was a genetic female with classic salt losing, CAH, mostly 21-hydroxylase deficiency. We did not do genetic testing because we see a lot of cases in Egypt due to high rate of consanguinity, and the high 17-hydroxyprogesterone and severe ambiguity pointed towards 21-hydroxylase deficiency. So the conclusions here, the triad of hypoglycemia, hyponatremia, hyperkalemia, of course, we think of adrenal insufficiency. Hypoglycemia is corrected after start of hydrocortisone, of course, in addition to IV glucose shots. Males with CAH could present with normal genitalia. They could come with precocious puberty in 21-hydroxylase and 11-beta hydroxylase deficiency. Females with CAH present with various degrees of genital ambiguity, ranging from very mild clitoromegaly up to complete male phenotype with undescended testes. And that's why it's very important to apply the workup of DSD for any apparent male with bilateral undescended testes. And this is not the case if we have unilateral undescended testes, there is no problem in that. Another spectrum of hypoglycemia is this 1-day-old neonate who presented with generalized tonic-clonic convulsions, lethargy, poor feeding, born at 36 weeks with a very large birth weight. He had RDS, convulsions. The mother has got uncontrolled diabetes, and there's history of type 2 diabetes in the maternal grandpa. It's clear that the baby was large for gestational age, puffy, plethoric, jaundiced. He was tachycardic, tachypnic, distressed, with cold extremities, hypotonia, and lethargy. So this is the typical infant of diabetic mothers. And based on these, we suggested the following labs. The CBC revealed a very high hemoglobin and polycythemia, and the random blood sugar was very low as well. Magnesium was very low, calcium was low, phosphorus high, and the PTH again was low. So this is functional hypoparathyroidism. And there was also indirect hyperbilirubinemia, and these are the typical metabolic errors in infant of diabetic mother. The baby was also found to have cardiomegaly and pulmonary congestion in addition to a VSD on the echo, in addition to right-sided renal agenesis. And this is because the mother was not controlled at all. That's why the baby has got a lot of anomalies. So looking at maternal diabetes, there's fetal hyperinsulinemia causing beta cell hyperplasia, macrosomia, neonatal hypoglycemia, hypoxia, polycythemia, and hyperbilirubinemia. Decreased lung maturation predisposes to RDS, and decreased parathyroid maturation leads to manifestations of hypoparathyroidism. And so it's very important to screen for hypoglycemia in infant of diabetic mother, even if not symptomatic. Hypoglycemia is transient in infant of diabetic mother due to transient hyperinsulinism. Screening for cardiac and renal anomalies is important, and also screening for associated metabolic problems is very important as well. Another exaggerated spectrum of hypoglycemia is this 2-day-old female newborn. She presented with recurrent generalized clonic convulsions in the fed and fasting states. She had apnea, cyanosis, lethargy. She had a male sibling who died due to neonatal convulsions in the first week of life, and the cause was not recognized. The parents are first cousins. The mother is not diabetic, and the baby was born large, but no dysmorphic features or congenital anomalies, as you see. The metabolic profile was normal, but their blood sugar was very low, as you see, and hypoglycemia persisted in spite of giving IV glucose, and the GIR rate exceeded 15 milligrams per kg per minute, and the baby is not improving. And so we withdrew the critical sample. Ketones were negative. This is non-ketotic hypoglycemia. Fasting blood sugar very low, insulin very high, insulin glucose ratio very high, and the rest of the profile was fine. We were also able to exclude inborn errors of metabolism, and so the final diagnosis of such baby was congenital hyperinsulinism. And the question is when to suspect congenital hyperinsulinism in a neonate with hypoglycemia. When we have a neonate with persistent hypoglycemia not responding to usual lines of their treatment, and glucose infusion rate is more than 15 milligrams per kg per minute, suspect hyperinsulinism. And as you see here, it's either focal or generalized, and sometimes it's even ectopic outside the pancreas, and this is very difficult as well. And when we need to differentiate the focal from the generalized, the gold standard is 18F-DOPA PET scan, which differentiates focal from diffuse. Of course, it's not available in all countries, and it's a very expensive way of radiology, but it's the most accurate. Now, looking at the mechanism of insulin secretion from the beta cell, imagine that this is the beta cell of the pancreas, and this is the potassium ATP channel formed of two subunits, KER6.2 and SER1. Glucose enters inside the cell by the GLUT transporter. By glucokinase, it forms glucose 6-phosphate, enters glycolysis forming pyruvate, which enters the Krebs cycle in the mitochondria. And GDH is stimulated by leucine, increasing ATP production. And this causes closure of potassium ATP channel, depolarization, opening the voltage-dependent calcium channel, which enters inside the cell, increasing the calcium influx, and the secretory insulin granules fuse with the membrane, causing insulin secretion. A very complicated mechanism, and any genetic mutation in such a step or mechanism could result in hyperinsulinism. And based on that, mutations that could happen are inactivating mutation in SER1 KER6.2, activating mutations in glucokinase, MCT1, GDH, or HNF4, and other unclear mutations. And here you can see the list of genetic causes of isolated genetic congenital hyperinsulinism. I need to focus on this part. For the potassium ATP channel, it's either focal or diffuse. If you look at the rest of enzyme transporter mutations, all of them are diffuse. So if you start by doing genetic testing, sometimes you do not need to do the PET scan. Looking closely at potassium ATP channel, there are two subunits encoded by KCNJ11 gene or ABCC8 gene, and this is the most common, though this is not the most common in Egypt and in Arab countries, and most of these mutations are not diazoxide responsive. There is a unique genetic makeup for focal congenital hyperinsulinism, and if genetic testing finds paternal ABCC8 KCN11 mutation, the patient most likely has focal congenital hyperinsulinism. In such a case, we confirm by PET scan. So it's not routine to ask for PET scan in every case. It's better to start by genetics if available. And this is a list of diazoxide responsive and non-responsive mutations. And here you can note that the potassium ATP channel mutations respond more to octreotide and nifedipine than diazoxide. So when we have persistent congenital hyperinsulinism, we try medical treatment for 1 month. If improved, assess and discharge. If unresponsive, do genetic testing, and then decide on the PET scan to decide whether it's focal or generalized. If focal, the only way is focal legionectomy. If diffuse, evaluate medical therapies. If there is adequate response, continue on long-term treatment. If not responding, unfortunately, it will be subtotal pancreatectomy. And the drug therapy of diffuse congenital hyperinsulinism, the first line is diazoxide. It opens potassium ATP channel. We do not have diazoxide in Egypt. I'm not sure what's the situation in India. We always give octreotide and triate. And there's also the nifedipine, calcium channel blocker. It blocks this pathway and decreases insulin secretion. There's the octreotide, which inhibits insulin secretion from beta cell and inhibits calcium entry into the beta cell. Now, updates on that baby. Genetic analysis revealed a homozygote mutation in KCNJ11 encoding KER6.2, confirming diffuse form of congenital hyperinsulinism. And the PET scan showed diffuse as well. The medical treatment failed in that baby. We tried giving octreotide and nifedipine. We reached very high doses. The baby did not respond. We do not have diazoxide. And unfortunately, 85% subtotal pancreatectomy was done, but the baby is thriving well. Normal neurocognitive development and the blood glucose is fine. It's not really that easy. There are some challenges when dealing with diffuse congenital hyperinsulinism. Some are not responsive to diazoxide and octreotide. Some will need subtotal pancreatectomy, and some will continue to have ongoing hypoglycemia after subtotal pancreatectomy. And don't forget the post-operative complications of removing the pancreas and getting it out, diabetes and exocrine pancreatic function. And there are some novel therapies for diffuse congenital hyperinsulinism that reduce the insulin secretion, like the long-acting octreotide, potassium ATP channel chaperones, insulin receptor antagonist, GLP-1 receptor antagonist, and mTOR inhibitor. Long-acting octreotide have been tried. The rest are still under research in children. My last case is a 1-week-old neonate whose mother is not diabetic, but was born large with generalized tonic convulsions. He was jittery, macroglossic, hemi-hypertrophic. He had umbilical hernia. And if you look closely, he has got some ear creases here and pits in the ear. The random blood sugar was very low, 22 milligrams per deciliter, and not responding to usual lines of treatment. And so the next step is the critical sample. Again, the ketones were negative. The blood sugar is very low, hyperinsulinism with high insulin glucose ratio, and the rest of profile was normal. Now, putting the features of that baby together, the diagnosis here is Beckwith-Wiedemann syndrome. And there are some typical features for Beckwith-Wiedemann syndrome, like transient hyperinsulinism, though presenting with severe hypoglycemia. Such babies are liable to multifocal tumors like hepatoblastoma, gonadoblastoma, and neuroblastoma. They have hemihypertrophy and they have macroglossia, and the ear pits are very characteristics. The conclusions here are suspect congenital hyperinsulinism if persistent, hypoglycemia requiring GIR more than 15 milligrams per kg per minute. Congenital hyperinsulinism is confirmed by critical sample of hypoglycemia and hyperinsulinemia more than 3 microinternational unit. 18F-DOPA is the current gold standard to differentiate focal from diffuse congenital hyperinsulinism. Genetic testing allows you to decide who will need the DOPA PET scan. We do not do it for every case. Some mutations are diazoxide responsive, others are not. This is if you have the luxury of having diazoxide. Failed medical treatment for diffuse necessitates near total pancreatectomy. And remember that congenital hyperinsulinism could be isolated or syndromic. Look at the features, look for congenital anomalies. And finally, a very important question I'll end by: why is early diagnosis and management of neonatal hypoglycemia crucially important? We need to save this baby's brain. Neurological sequelae is so severe. We see a lot of CPs due to uncontrolled hypoglycemia, mental retardation, seizures, developmental delay, personality changes, and therefore early detection and management of hypoglycemia prevents serious neurological sequelae. It's very important to suspect, diagnose, and treat according to the cause. My final thoughts are: screening and management of neonatal hypoglycemia is important. Early diagnosis and management avoids serious neurological sequelae. The critical sample is mandatory in non-responders. Most cases, luckily, are transient and resolve spontaneously, but some of the causes are permanent and require aggressive and specific management according to the cause. So we need to be careful, diagnose, and treat. And finally, this is the blood sugar fairy. She says, I'm the blood sugar fairy. If you see me, your blood sugar is too low. Thank you very much for your attention.